So I'm going to talk about pilon fractures, and specifically complex C3 pilon fractures, so the really bad ones. And I'm going to talk a little bit about a change in the way that we're thinking about fixing these, and see what you think. These are my disclosures. None of them are particularly relevant to this talk. This is St. George's in London. It's one of 4 level 1 trauma centres in London. There are 4 of them. I work in the southwest of London, and we take quite a lot of high-energy trauma. We serve a local population of about 1.3 million, and we have a fairly big hospital by UK standards. I recognize by Indian standards, 1,300 beds isn't necessarily that big, but we're a regional center for most specialties. I myself head up our limb reconstruction and orthoplastic and complex limb reconstruction service, and we have quite a high volume of open fractures and polytrauma patients. So whenever you read anything in orthopedics, you can typically find a piece of literature to support the argument for whatever argument you're having. So when we talk about pilon fractures, for example, plating versus framing, you can find an argument for either in the literature. If we look at pilon fractures in particular, and we go back through the history of intra-articular distal tibial fractures, Rudy and Algoer gave us the first classification of these. Now, Rudy and Algoer were the Swiss chaps who lived in the Alps and were the founders of the part of the AO and so on. Many of these injuries were rotational pattern injuries of the tibia that extended into the joint and don't necessarily represent the super high energy injuries that we're seeing today. But what they did note was that there is a particularly poor outcome with distal tibial fractures. And in their hands, they had a 26% poor results, but in other people's hands at that time, the complication rate was up to 50%. So really bad injury with bad outcomes. We looked at this in a bit more detail. This is one of the papers that I wrote when I was on fellowship in Liverpool with some famous orthopedic surgeons, Indian names, Badri Narayan and Malaysian Durai Nayagam, pretty famous names. And we tried to produce an algorithm for how we should manage high-energy tibial fractures. And this pushed us towards a frame for the most severely injured patients. So I ask you, if you have a case like this, what would you do? This is a typical, what I would call pretty high-energy pilon fracture, bad comminution, and especially comminution at the articular surface. What would you do? Now, we had a trial going on in the UK called the ACTIVE trial, where patients were recruited and they were randomized to either plate or frame for this type of injury. I was on call, this patient came in, they got randomized to plating. And I was like, I wish they'd been randomized to framing. This is a particularly nasty one. I would normally feel more comfortable framing than plating. So how do you even begin thinking about plating one of these fractures? Typically, when we think about plating of pilon fractures, one of the concerns is non-union and failure of fixation at about 3 or 4 months in the metadiaphyseal region. I'm sure you've all seen this. This is where the plate fails. We focus on the joint, and the metadiaphysis is where we see that non-union failure, not dissimilar to the distal femur as well. If you look at the original classification, is it particularly helpful in helping us decide how we go ahead fixing this? I'm not sure it is. It's just describing the severity of the injury, but it doesn't give us a guide to how we should fix it. Subsequently, we've seen newer classifications looking at the anatomy of the articular surface. So this was the paper from Topless, where they tried to map the predictable fracture lines in pilon fractures. But what you'll notice is they had about 20% of the fractures they couldn't even classify. So the system itself isn't really set up to look at the highest energy injuries. And if you open up your AO manual, it will show you these fantastic pictures of a joint lovingly being pieced together with some wires, and then all of a sudden you can slide a plate up the leg and join your joint back to the tibia, and all will be good and well. I'm sure you've all read your AO manual. Trying to replicate this in the context of this injury is extremely difficult. Rudy and Algoa told us that a good outcome should be expected if you can restore the articular surface anatomically. But I'm not sure that you can do that in every case. In this case, for example, we can. We've got a good articular reduction. This looks remarkably similar to that AO picture. A few screws, an articular plate, slid up the leg, good result. But when we have this, trying to do the same is going to be very, very difficult. The other thing to think about is that it's not just the bone, but the cartilage injury in these injuries is significant. The chondrocyte death is on the cards from the day one. So even if you restore the anatomy perfectly, the chondrocytes themselves are going to struggle, and we're going to see post-traumatic arthrosis. And the literature will tell us that the outcomes of these injuries are particularly poor with ongoing pain, ankle stiffness, post-traumatic fusion. So if you have a high-energy distal tibial fracture, you know that it's not a good sign for the future. So I think the goalposts are moving, as we call it in the UK. The focus of how we treat these is changing. And for me, the focus is away from focusing on the joint and much more focusing on overall alignment of the reconstruction, stability of our reconstruction, what we call talar containment. So trying to keep the talus under the tibia in its correct anatomic location, aligned and stable, and restoring that distal tibial bone stock for future fusion or future salvage. And the articular restoration is less of an issue. So really what we're working from is top down rather than bottom up. And this is what I would call column restoration. And we're familiar with the concept of column restoration when we look at the tibial plateau, when we look at the distal radius, even when we look at the acetabulum. We're thinking about column fixation. But it's not something we've routinely thought about in the distal tibia. This group from Korea looked at this, and they showed that in C3 fractures particularly, obviously, the majority of them involve either 3 or 4 columns. And we have to think then, if we're trying to achieve stability, how are we going to do this on a column-by-column basis? So let's go back to our case, and we look at that, and here's the CT. Where's the strategy? How do we even begin putting this back together if we're plating it in a way that's going to give us that targeted column-specific restoration of talar containment and alignment? We have to use our cross-sectional imaging. It gives us our ideas about our working windows. How are we going to reduce it? How are we going to fix it? We've got to be considerate, though, of the blood supply around the distal tibia. And for me, that's a really key part. How do we do this in a biologically friendly manner if we're going to be using a lot of hardware? One key thing for me, and I would encourage you to explore this, is I have universally stopped using a tourniquet now for about the last 8 or 9 years. And if you look at tourniquet usage, there is very little evidence in trauma surgery, and I know that, for example, in knee replacement surgery, it's almost now going out the window. But in trauma surgery as well, there is very little evidence of the value of a tourniquet. And in a high-energy pilon fracture where you have a significant soft tissue injury, I don't want an additional 2 or 3 hours of tissue hypoxia around that soft tissue envelope as well. So here's our case, and my first thing I'm going to do, and I'll talk you through my approaches, but I do most of these through a combined anterolateral bed of peroneus tertius approach and a posteromedial approach. That gives me almost 360-degree access around the tibial plafond in a very soft tissue-friendly manner. Here you can see I've put a plate on the fibula. That's an anterior plate on the fibula, not a posterior plate. So it's anterior, and that's restored my lateral column. I've got a mini fragment plate on the medial side. The wire is bent just so it comes out of the soft tissues without causing tension. But that's restored my medial column. And all of a sudden, just with those 2 implants, the talus is looking like it's not far off where it should be. I can then take the next stage of the operation, which is to take a plate, and I've contoured it to match the back of the tibia. And you'll notice there's virtually no screws in this. This is a 20-hole 2.7 plate. There's 2 screws at the top end. All that plate is doing is giving me a template to build against. I've used a femoral distractor into the talus just to give me some additional ligamentaxis. And very suddenly, the joint is starting to come back together, but I haven't focused on the joint at all. I've just focused from proximal to distal on reconstructing each column in turn. And then I can go on and add what I would call my heavy-duty hardware, the workhorse plate, this anterolateral plate that gives me my fixation strength and allows me then to have the confidence to rehabilitate and get this patient mobilizing. So here they are at about 3 months post-op. This patient was allowed to weight bear at just 2 weeks post-op after the wounds had healed, early range of motion, early weight bearing. Those are two things I feel very passionate about, and that gives us a fairly good radiographic result. How do I do it, though, in terms of the soft tissues? You have to be meticulous in handling them. So that's why I'm no tourniquets, no retractors, no pinching the skin edge, paired incisions. So either the yellow pair or the blue pair, so that's that anterolateral posteromedial combo that I talked about, or anteromedial posterolateral combo. And I've moved away from the universal anterior approach to the distal tibia, the one you see in red at the front, which is what the foot and ankle surgeons may use, for example, for elective fusions or ankle replacement, because it's not a very soft tissue friendly approach in terms of trauma, and it involves opening up the retinaculum, which itself is a problem in terms of reconstruction later. So I don't use that approach at all. If you look in your notice, I used a lot of mini fragment plates, so a lot of 2.7, even 2.4 and 2.0 plates. Those have become a really big part of my practice. But if you look at this paper where they talked about the benefits of mini fragment fixation, I pulled out all of their failures. And the issue here is they're using mini fragment fixation in isolation. You'll notice I still used a 3.5 periarticular plate, what I call the workhorse, the one that's the strength of the construct. And if you don't have that, I don't think these plates are good enough in isolation. And they've also chosen to base their medial-based constructs here for lateral displacement fractures, which is a very sort of mechanically poor or disadvantageous construct. So just be wary of that. Going back to the Korean paper, if you look at their data, they had 23 patients and all of them united. But if you look at their data around infection, and let's be negative here and say that a dehiscence was an infection, that still represents less than 10% infection rate for high-energy complex pilon fractures treated in this fashion, which is lower than the traditional infection rate in the literature. Our data at St. George's has been similar. In the last 5 years, for our C3 pilon fractures, we have about 120, a few more now. We had about a 30% deep infection and complication rate when treated with single plate in isolation. But when we've done this column-specific fixation, we've had a much lower non-union and infection rate. And I think when I go back to comparing frame and plate, I don't think that that plating construct is in any way comparable to a ring fixator when it comes to mechanics. They're totally different. But maybe when I've started building my internal fixation circumferentially around the tibia, the mechanics of my internal fixation now maybe match or get closer to the mechanics of how the circular frame works. And we know that stability is something that is hugely important in preventing infection. So there is something in there about providing enhanced stability. So people get very concerned that increasing the amount of metal increases the infection risk, but maybe increasing the stability is reducing our infection risk, and that's an important thing to consider. So I think there is a good argument for column fixation and this sort of what I would call heavy metal fixation in distal tibia, but it needs to be very clean. You have to be very careful and meticulous with the soft tissues, and you have to achieve really good stability, alignment, and containment of the talus. So there you go. That is my means of thinking about the distal tibia, the tibial plafond at this time, and how I've changed the way I fix things. Thank you. Should we do questions after?
Questions we'll have it after.
Perfect.
Yep.
Thank you.
I think the next speaker needs no introduction except for Derek and Alex to know who he is. Ajit is a very familiar name, very well-known name in the Indian as well as in the, associations abroad as well. Basically, he's literally one of the senior consultant in Tejasvi Hospital, the private hospital in Mangaluru, and Shantaram Shetty Institute of Traumatology, Orthopedics and Trauma in Mangaluru. He completed his medical degree in Osmania University, and obviously did his post-graduation KMC. Eventually, he did get his training in the UK and Ireland as well, probably with much of Guinness, no Guinness. And he had his MCH from Liverpool with, I think, that is one of the things which a lot of Indian doctors and people abroad has been looking forward for the training there. He is specialized in joint replacements, complex trauma like Alex, and pediatric orthopedics as well. He has delivered innumerable lectures nationally and internationally, and he's one of the good teacher. You got to listen to him, and he will interact, inculcate, and probably trigger the lateral thinking in your brain. Mind you, folks, he's going to come now in the next. He has published huge amount of publications, and he is a chairman for AVO Trauma in India for about 3 years, which is going on now. With much ado, Ajit, your time.
Thank you very much, Amarnath, for that introduction. First of all, I must congratulate Alex for one of the brilliant talks that I've heard in the trauma. I think a very good approach, and with our interest in trauma across the country, I think everybody will be really appreciating that. It's a real lateral thinking, I should say. Anyway, my brief is to talk on atypical subtrochanteric fractures. Since I have only 10 minutes, I will be making it a little bit interactive. I want some quick fire answers to the questions that I ask, and then 5 minutes I will dedicate, 3 cases I'll run through, and then 1 case last for interaction maybe. Let's see how it goes. Diagnosis, quick, anybody? Paget's, osteopetrosis, anybody? Fluorosis, okay. Anyway, what you're seeing there, I think I'll run the arrow there. You see that? There's an impending fracture, and this patient was suggested prophylactic fixation, and as usual with our patients, they walk away. I mean, they can't afford or they don't trust us. And yeah, there was no bisphosphonate use here. And that is rugger jersey appearance in the spine and the skull that you can see. It's osteopetrosis, okay? And 3 months later, this is how she comes. And now how to fix this? What implant? All of us know that it is a very, very hard bone. You need a lot of drill bits at hand. You need, you know, armamentarium there. Okay, so this is what was done. I don't have the initial x-rays, but you can see from the short DHS that that's as far as I could go, you know, with all that effort. And this, of course, eventually healed well, but what you can see here, already there is something happening on the other side, right? Okay, and complaint of pain, and that progresses, okay, there, and suggested surgery, not willing. This was after 6 years after the opposite side. Suggested surgery, and then comes back after about 12 months. So this is the type of mentality or the compulsions our patients have, so that's what happened. What now? What to do? So pretty much the same, I guess, because the DHS worked the other side, you would try that. So, okay, nailing is out of question anyway. So again, tried DHS, went through the, sorry? But you can't ream through, that's the problem. Huh? No, nailing to ream, get your reamers down the canal, it's impossible. So, and then you got to think of also the thermal necrosis that might produce there, okay? And then the triple reamer just would not go through there, okay? So that's, we struggled quite a bit, and you see that even the guide wire would only go up to there with all that effort. And so on table we had to change, right? So we went on to putting a plate like so, okay? Now the thing is, will this fail? So I'll come to maybe the message later about this. So maybe a little rigid type of fixation, the AO people might say, but then we wanted some sort of good feel on table. So this was what was done, and delayed weight bearing protocol, and then that went on to heal, okay? So this is one case. I'll just run through another case. In a 14-year-old boy, diagnosis. Anybody has come across this? Quick. 14-year-old. Diagnosis? Diagnosis? Even I was not aware of this. It is pathological. It is Piles disease. Okay? So it's a genetic aberration that you can see, and there are some skeletal issues that can happen here. And this was how it was fixed, right? And yeah, again, bit of alteration in your weight-bearing protocol because it is a surface implant, right? So the third case, this was a young man who had undergone some surgery 7 years before. The details were not available. He had some pain in the thigh. And this was the old radiograph the patient had. The diagnosis here, it's all on subtrochanteric fracture. So this is, you can see some pathology there. You can see some pathology there. So he had a fracture, right? It was a fibrous dysplasia case, and so this was a second surgery he had undergone, and that went on to fail, right? So obviously it needed exchange nailing, bone grafting, and this is the current thing that most of us do. You need, for subtrochanteric, particularly failed fixations or pathological entities like this, you need very strong fixations to control the torsional forces that can happen in this area, okay? So that went on to heal well. I think that's my 5 minutes done. Yeah, I still have 4 minutes there. So that's healed. Now, this is a 60-year-old lady. I want some inputs from the audience. Dwarf like less than 5 feet, 4'10" or so she was. And all the time with a stiff hips, she's been walking with a walker. And she stumbled and had a fracture, okay? So, I'm not going to ask Anil or Dr. Clegg about this because they will